is your take on this laboratory assessment of all these inflammatory markers? Can we do it here, or we have some limitations? Or is just overall comments, because you're the youngest of the lot, and I think you have most recent update in this field.
Well, thank you so much for inviting me. First of all, it's a pleasure to be here, particularly on a platform with you. Professor Vyas Saab is sitting right beside you. It's an honor for me to be on the same platform as you guys. As far as COVID-19 testing is concerned, as you can see, the world over, the world has gone through a crisis of diagnosing these tests in time and in the right numbers. People say that Pakistan has had a shortage of tests. If you look around, every country has had a shortage of tests. And for the last 3 months, the entire focus of testing has been on the PCR test to diagnose acutely ill patients or people who are even in the incubation stage or people who are actively infected. And the focus is now gradually shifting to also add antibody testing to be able to diagnose people who were infected and perhaps did not notice, did not have symptoms or had mild symptoms and have probably started recovering to some degree and may, based on, depending on who you listen to, may have some level of immunity. The WHO keeps insisting that presence of IgG antibodies does not necessarily mean that people are immune to it, but still, may have some level of immunity, at least for some time. As far as testing for interleukins is concerned, these tests can be made available. These tests are routinely not performed in large numbers, but they can be made available. As you can imagine, they are on the back burner of pretty much any lab around right now. But they can be made available within a couple of weeks if there is a requirement for them, and I think there will be a requirement for them because our first response was to stop everything, to stop all outdoor activities, to stop all elective care. But elective is a very broad term, and it includes, unfortunately, time necessary, time sensitive care also. If somebody has a tumor, or if somebody has a life altering condition, then that is not necessarily an elective procedure. It is a mistake to bundle those in with cosmetic procedures, for example. So in the days to come, we will have to have the capability to monitor, to be able to test them quickly, and to also, as you suggested, to be able to assess inflammatory interleukin levels as necessary to be able to manage these patients effectively. And they can be made available in fairly short order.
Thank you, Umar. Dr. Bang Bang Darwono?
Yeah, thank you. So I'm not a biologist or virologist, I'm an orthopedic surgeon, but my team have a pilot project to treat a patient with COVID-19, and only just small number or the 3 number. I will report them and we put in some theory for them. Can I show my slides?
Yes. Okay.
Thank you. So this is my presentation. So this is, we know all about the anatomy of the virus like this. And also we can see here there's a lot of protein, the S protein, the E protein, the M, HE, N, and also genomic of the RNA. And you know that the viral genome consists of more than 20,000 bases and code 29 proteins. And this group also protein include the main protease NSP5 and polymer. So the coronavirus protein mimics the protein composition of the exosome. Very common. And here also, it hacked the way into the host of the cell. So what makes the virus so good at infecting people? How does it reproduce so quickly once it is inside us? And why doesn't the virus cause symptoms right away, allowing its spread undetected? So we know that immune defense from the literature, antibody is a protein immunoglobulin produced by B lymphocyte in response to a specific triggers by foreign substance. They identify and neutralize their target. Why infection occur? Because at least one important part of the immune system is not working. So this is the lymphocyte. Generate an immune response that specifically and maximally target that pathogens, but they also generate memory cells for future protection. So this immunity is a conditioning immune that permits innate and adaptive resistance to disease. And through proper recognition and management of external infection pollution and internal, like wound repair and program cell death challenges. And what is essential purpose of the immune cell is very important, and also understanding how living with a primary disorder immunity can affect the daily life, and understanding which part of our patient immune system is not working properly. So again, what exosome is, we already from tomorrow release to extracellular environment and exhibit lipid bilayer and contains protein and nucleic acid and messenger RNA and microRNA, and play a role in cell-to-cell communication, have a cell-free regenerate potential, and available found in body fluids and many other fluids in our body. So this is biokinesis of the exosome, and also sorting protein, lipids, and RNA. So the content inside exosome is protein, lipid, and like this. And this is the protein composition of the exosome, and how packaging the Myrna, and this is the Myrna profile in exosome. So this exosome is a nano-sized cargo vehicle. So how does it work? Uptake by exosome by other cells, intracellular signaling, RNA proteins, and interaction. But this also hacked by the virus, and the virus go inside the cells. So antigen presentation, immune regulation, spread of infection if the exosome already infected, epigenetic changes, promoters, it can manage the gene and then change the expression of the gene, tissue repair and regeneration. So here, the mesenchymal stem cell, they produce exosome and many others microvesicle. They can inhibit replication of the virus inside the cell. They can do immunomodulation. They can do also regeneration of the destroyed tissue. So this is virus life cycle hacking. Binds the receptor, and then this release RNA into the host genome, and also assembled into virions in the endoplasmic reticulum and Golgi apparatus.
Excuse me, Dr. Bang Bang, I think nobody, at least I can't see your slide. I hope everybody else is able to see your slide. You have to share the screen. You have to share the screen.
Oh, let me, how to do that?
Just click on share screen. At the bottom of your screen, there's a green button called share screen.
Okay, so I will end this.
Just click that.
Sorry. Here. Yes, and share.
Share, yeah. Now you can share, yeah. Yes.
It's okay?
Yeah.
So I continue or repeat?
Yeah, continue please. Thank you.
Yeah. Thank you. So this is intercellular communication, antigen presentation, immune regulation, spread of infectious disease if this exosome is already infected. Now we can see here, if after they hack and change everything there and then infected the exosome and spread the virus to other cells, then become the cytokine storm with extreme release of cytokine activity in a lot of this cell. And Professor Godip already mentioned about this. So cytokine storm is hyper response from our immune system induced by viral infection and replication. Virus derive exosome contain protein and RNA to regulate gene expression and the survival condition. Virus also secreted exosome TAR RNA to stimulate the expression of intracellular pro-inflammatory cytokines. So many pathways to induce the cytokine storm, not only inflammatory mediator EL6, but also another pathway, mTOR and GAK pathway, etc. So body hyperresponse, they're deadly than the virus itself. The disease cause is determined by the viral replication and immune response. Not a single drug nowadays yet approved to killing virus, only inhibits certain viral activity. Not only inhibit the EL6, but also inhibit the mTOR, inhibit GAK pathway, control the immune response and regeneration of the destroyed tissue. So why immune cells are out of control? And what can we do to ramp them? So what is the role of exosome? Here is the virus go inside and hacking everything, and then come out with the exocytosis, with the exosome, infected exosome, and infected another cell. So what exosome can do, because this is really the domain of the exosome itself. So the healthy exosome, you just put inside microRNA, messenger RNA, and this will do a gene silencing of this. So inhibit the translation and also replication. This is inside the cell. So this is how modulated regulation by exosome in the cytokine storm from this literature have been identified to exert an inhibitory effect on immune response by carrying immunomodulatory effectors such as transcriptional factors, non-coding RNA specific to the species, and cytokine. In addition, stem cell derived exosome to impair dendritic cell maturation and to regulate the activation, differentiation, and proliferation of the B cell. They have shown to control natural killer cell activity and to suppress the innate immune response. So this is how in regeneration we can see this in literature, and this is the way they can stimulate the activity of the progenitor, local progenitor, and also like this. This is also for regeneration. So this is our case report. We just only have 3 cases. This is a lady, 35 years old. And this is before exosome, and this is after exosome, the fever, headaches, respiratory symptom, fatigue, myalgia, and everything. And this is laboratory, leukocyte, platelets, and CRP. This is procalcitonin and ferritin high, and then decrease after the given by treatment with exosome, and this is only just for 2 days after giving the treatment. Another case, this is 73. This is before the clinical data. This is after. And this is the laboratory and radiology before. Ferritin is very high. Then just 2 days, 0. Another case, just the 3rd case, 54, a lady. This is before exosome, and this is after exosome. This is also the ferritin, very high, decrease, but not yet negative. So these all clinical symptoms improve after administration of the exosome injection intravene. So I just share just small number. And this is our team again, and this is our lab. Thank you very much.
very interesting presentation, and I think it gives us some idea that exosomes and their products they does help in breaking this inflammatory cycle and the cytokine storm. Maybe we'll have some comments from Dr. Ghassan Abitayyab about the whole scenario.
Well, thank you very much, Professor Tariq, for inviting me here to join this August gathering. Although my subject is liver, but since it's COVID everywhere, and right now we think that it's COVID-19 unless it's proven otherwise, and we are no exception. In our field, a number of patients are presenting with GI symptoms at the same time, liver enzymes elevation. Few of the patients have liver enzyme elevation in the range of 3 to 4 times of the limit of normal, but the ones who go into cytokine storm, they go into thousands, and that's understandable. That is part of the systemic inflammatory cascade. And Professor Bang's presentation is very encouraging on this side, that mesenchymal cell related exosomes, they help in controlling the inflammation. And I'm particularly worried about our country, where 45 every 10 persons suffering from chronic active hepatitis. And although we have been able to treat quite a good number of people suffering from hepatitis C, but even the ones who have been treated with hepatitis C, 45% of them, by the time they got the treatment, they had significant liver fibrosis. So meaning by that, in the community, we have a huge number of patients who are having significant liver fibrosis, which need management in terms of anti-fibrosis, that Professor Kuldeep and the rest of the people have rightly said that we need to have pilot studies on this account, that if we have that much degree of liver fibrosis, and we have COVID-19 as well, another insulting factor. So we have got two issues. First issue is, if we've got liver fibrosis and we want to revert the liver fibrosis, can the exosomes help us in that? The certain studies have shown that they do help, but then we need to go further. So that's one aspect of the whole thing. And then in the current scenario, when we have COVID-19 in the background, so many people suffering from liver disease and COVID-19 potential to disturb the liver as well as a part of the systemic inflammatory condition. So in that, the people can have a worsening of the liver function, people can have worsening of the condition, people can have decomposition of the disease. And we as a clinician, we need to be proactive in identifying the people presenting with decomposition at this stage, thinking of COVID in this era, even when the suspicion is very low. And exosomes in the management of liver disease as part of COVID, I think Professor Bang has very rightly pointed out that it does have a role, but after set procedure, right now we are in the initial phase. We don't have any definite anti-viral treatment. There's so many drugs which have been tried, starting from nebulized interferons to chloroquine as an entry inhibiting agent, and then the new drugs like remdesivir. But then still we are in its infancy, and running the pilot study on exosomes, and then taking further, if the COVID stays with us, which is most likely to stay with us for maybe many months, maybe a few more years. And in that context, I think it will be very important to go ahead with the pilot study and then phase 1, phase 2, phase 3 study to evaluate it properly, whether it can help in its real way, and can we control the disease with the help of exosomes, in addition to so many other things that we are trying at the moment. I'm really, once again, thankful to all of you for allowing me to join. And can I have the comments of Professor Kuldeep on this issue? I'm really excited to see Professor Kuldeep on the screen. Thank you very much, sir.
Thank you. At the onset, I must say that let's assume one thing for sure. Stem cell, we are not talking about antiviral treatment for the patient. Let's be very clear on that one. Yep. Stem cell cannot be antiviral at the moment. What stem cell really do, particularly the mesenchymal stem cell, as pointed out by other speaker as well, is the secondary phase of the effect of the virus, which is a fibrosis and cytokine storm, which has a very significant role. The number of deaths worldwide, as you know, has crossed 200,000 people. So the role of stem cell is not to control the COVID-19. The role of stem cell is to manage the people who are dying under ventilation. So if we can help in that area, particularly having a trial on patients who are on ventilator and look at the profile of interleukin, whether with the exosome or conditioned media or mesenchymal stem cell, the fibrosis, as pointed out by the last speaker, is a very significant role mesenchymal stem cell can play because they inhibit the synthesis of collagen. So that can be antifibrotic in a way, but that need to be tested in those patients. So I'm quite optimistic that if we do a very controlled trial with the definitive answer at the end, not the cure for the virus, but at least the management of those patients, bringing down the ferritin level low or the LDH level low in those patients by treating with exosome or with the conditioned media will go a long way in solving some of the major problems, which I think community is facing at the moment, not in terms of developing vaccine or curing a virus per se, but managing those patients who are dying under the ventilator.
Thank you, Dr. Jawad. Jawad.
Dr. Bang mentioned mTOR. So I was wondering, is it mTOR complex 1 or is it mTOR complex 2? Because they have slightly different characteristics. mTOR 1, for example, is associated with lysosomes, whereas mTOR 2 is higher up in the ladder.
Yeah, thank you. So what I understand from the literature is that there's so many pathways that create the cytokine storm. So you mentioned already that, but what I mean is like the drug remdesivir, this already to control the EL6, but the thing this is only to inhibit some action of the virus, but not killing the seem like the chloroquine. This only at the beginning when the virus starting to put the cell. So that is why we try to understand what the role of the exosome. Exosome can have 3 points. First, in silencing inside the cell, because this is the domain of the exosome itself. The second, he can modulate and regulate the cytokine, and the number 3 is just to regeneration the supposed alveoli already destroyed by the process. So maybe this is the chance of the exosome with a more direction compared to other drugs that we now trying to use.
Actually, I was talking about mTOR, mammalian target of rapamycin, but that's okay. Have you ever tried a comparative trial between exosomes and this mesenchymal stem cells, autologous mesenchymal stem cells? Because there has been news coming out from Middle East that mesenchymal stem cell therapy directly has also has initial results seem to be very encouraging. So have you ever done a comparative trial between these two?
Oh yeah, I don't make that comparison yet. But what I understand that the exosome also derived from the mesenchymal cell. Yes, secretome
Yes.
and exosome.
Yeah. Yes, we talked about that yesterday. Yes.
So okay, and the other thing is, if we give a cell therapy, there is some problem with cell therapy. It is from 100,000 be injected into the body, maybe only less than, it's literature to say less than 1% is alive, and then bring also the DNA if the DNA want to become a carcinoma, so it occurred and already reported. So this is the problem of the stem cell. Why we go now to the active, the cell-free therapy, but it is also derived from stem cell.
I was the other thing I was wondering. Have you checked? Do your exosomes do they have MHC1 and 2 on their surface or not? Major histocompatibility complexes or HLAs. Do your exosomes have MHC1 or 2 on your the ones you're using? Do they have those proteins?
Yeah. So I'm sorry, maybe I cannot answer that detail. I'm not biologist, okay? But my team will. Sorry about this, yeah?
No, because that has to do with immunogenicity of the exosome. That's why I was wondering, because they don't seem to. I'm layman as far exosomes are concerned. I'm just learning because of Dr. Tariq. He got me on track. I generally deal with the mesenchymal stem cells. I've been trying to I set up a system in King Edward Medical University here, and now I'm heading the Department of Regenerative Medicine, University of Health Sciences, besides physiology and cell biology. So yeah, I was wondering because immunogenicity has immunogenicity been ever a factor in using exosomes? That's what I was wondering about.
Okay, thank you for your information.
I can intervene, Professor Ahmed.
Okay.
I can answer that question. I think yesterday I pointed out that the mesenchymal stem cells don't have MHSC on their surface. So that is why they are generically used without being affected by the immune system. If the exosomes are derived from mesenchymal stem cell, understandably, those exosomes will also lack MHSC, major compatibility antigen, on their surfaces. But by and large, in mesenchymal stem cell, there are no MHC reported in literature.
Thank you, Kuldeep. Now, I think let's go to a situation where you have a patient who comes with a spinal injury, and after you admit him and he needs surgery, you don't have time to test COVID, whether it's a COVID positive or not. Then subsequent the course of treatment, it becomes apparent that the patient becomes found to be a COVID positive. Now you have two situations. The one, the patient has an injury, it has a trauma on its own. Then you have a patient who had undergone surgery, and then the COVID positivity comes into play, and then you have a two sort of situation which are not very helpful to the patient. How to handle this kind of scenario? I question to Ani, Desmond and Kuldeep and other pundits who are sitting there. Yes.
Difficult question. You're right. What I do is, in my practice, I go for history and history first. A history of traveling, history of contact, history of everything before going for any surgery. So this gives you some idea that if he has got COVID positive or not, and maybe his relatives are in close contact with that person, any person coming from outside, from abroad. Number one. Number two, the patient coming from the area. Is there any patient COVID positive in that area or not? So this is what I do. It's my, you can say, pre-surgery evaluation of the patient. So in such situations, I'm pretty sure the patient is COVID negative. But if the patient becomes COVID positive, then I think we have to proceed according to the WHO guidelines, and we have to fumigate whole of the theater. We have to quarantine all the persons who were involved in that surgery in the OR, working over there, and we have to close the OR as well. I think more colleague can tell us if something is missing.
Can I interrupt?
Please.
In the community, when we are going through a community where it's a pandemic, problem is there almost everywhere. It's not just that the problem is there in one part of the city and one part of the country or one country alone. The problem is almost everywhere now. It's a pandemic. In this scenario, I think what we need to do is that to save, to protect ourselves, to protect our colleagues, to protect our systems, we need to suspect every case as a COVID positive unless proven otherwise. And if a person has presented, I understand that Professor Hanif has said that a contact history with ex-person, contact history with foreign travel, all these things are very good. I think they were applicable when it was just an imported disease. Now it's there in the community. Right now, before we proceed with surgery, or we take the person to the endoscopy room or to any other procedure room, we need to have a test of that. Or if the test is not possible, at least a symptom analysis must be there. And symptom analysis is very simple. Although 80% of the people are asymptomatic, it's only 20% of people who are symptomatic. But even in those 80%, with a careful testing, people have realized that some kind of flu can be obtained. A certain change in the behavior, certain change in the smelling properties, certain change in the appetite, or feeling of being unwell can be elicited from these patients. So in that context, I think we need to have a very low index of suspicion. And we need to check COVID-19 PCR, or maybe just actually these patients. Radiologist is here with us. She can guide us better on changes on chest X-ray and maybe CT scan. Although we're not going to run CT on these patients, but at least a portable chest X-ray can be done in these patients who are even minimally symptomatic.
Dr. Farina, how sensitive is this radiology in the initial phase? Because we have a scenario in this patient is asymptomatic. He had undergone some kind of emergency and he had a surgery carried out, and then it becomes apparent that he is a COVID positive. There are two questions. One is from a radiological standpoint, that how critical is or how important is that you can diagnose on X-ray or CT. And second thing is more of therapeutic side. How the two initial injury, the surgery, and the COVID positive syndromes, they act together, and how to handle them in the way of so that the patient can be saved from further insult or some other critical scenario or the condition in which he might end up in a very critical
So
stage.
thank you very much, Dr. Tariq. So there are basically two questions that over to me. Number one is the sensitivity of imaging. So we have been using just X-rays, portable, and CT. Can you hear me?
Yeah.
So currently we are using portable chest X-rays or X-rays. Otherwise, when like patient of trauma comes to us and we need to do imaging, we will definitely send a portable X-ray machine to the department. And secondly, CT. As far as sensitivity of these two modalities are concerned, for the initial 3 to 4 days of the onset of symptoms, we consider day 1 as the day where on which the patient develops symptoms. Right? So within 3 to 4 days, the imaging sensitivity of both the modalities, X-ray and CT, is comparable. It's approximately around 50 to 56% both. So we can't rely really on portable X-rays or CT in those cases. But according to the guidelines, there has been published recently in ACR that in case of trauma patients, you do need to send the patient for imaging, or you can order portable imaging if the facility allows you to do that. Secondly, in case the patient has worsening symptoms, you can order CT or other imaging, and we rely more on portable chest X-rays as compared to CT chest here. So Dr. Tariq was concerned about patient who has come to us with trauma.
Can we give this kind of patient some IVIG so that they can boost the passive immunity? I mean, we are not treating virus load or anything, but we are dealing with the immune deficiency which have been produced by both surgery and the trauma and the COVID syndrome. So we can boost up sort of non-specific immune status so that it can combat both sides of inflammatory cascades. Any comments on the whole panel, Umar?
If I may say, these problems might be easier to solve in a few weeks. We are going to start getting some point of care molecular tests, which are be able to, I mean, right now our problem is that we have a lot of patients, and so you want to run PCR inside the lab with high throughput instruments. But in a few weeks, I'm anticipating these tests are already available in the US and some other markets also, and we are lobbying very hard in Pakistan also. So I foresee a situation where pretty much all hospitals and will have in their in-house a point of care molecular instrument, which will be able to do a COVID PCR test. And so you will have within 10, 15 minutes or 30 minutes, you will have a result regarding the COVID status of the patient. So that I think will go a long way toward fixing this problem regarding emergency patients.
What about the IVIG?
As far as IVIG is concerned or IgG is concerned, I mean, of course, research projects are ongoing. We have actually facilitated a couple of patients with potential IgG positive donors, but IgG testing is going to become more commonplace starting next week. We are anticipating the delivery of some reagents later on this week. In the next couple of days, we will have to do some in-house validation, and I imagine that will be the case with all the other institutes that receive those reagents. But within the next few days, we will have global standard IgG testing available on global standard testing platforms. As you know, there is a flood of these ready-to-use devices to do IgG testing and IgM testing, but they're truly not reliable. We have assessed quite a few of them, and the best that we have come so far is at 75% sensitivity and much lower specificity. So, but once we have fully automated instruments ready to go with these high throughput IgG testing, which I imagine will be the case, 1 week from today, we will have it available. Almost certainly we'll have it.
Tariq, if your question was regarding intravenous immunoglobulin, up till now, these trials which have been done, that they have failed to show any significant improvement in the outcome of the patient. But if we talk of the convalescent serum, yes, in the convalescent serum, especially in the people who have got advanced degree of lung disease, and they are into a phase of cytokine storm, in those cases, convalescent serum does show that there is improvement. The recovery chances improve, the stay in the hospital improves, and the virus clearance improves. So these three endpoints, on all these three endpoints, the convalescent serum does show some benefit.
Thank you. Any comments from Desmond? He's been sitting quiet.
No comment. No comment. The only thing is that a lot of stuff is really on the practical side, and in our institution, we're facing the similar situation, as to say, we sometimes do not have the chance to know whether the patient is COVID positive or not. So, and those patients, say for a trauma patient, they need the surgery. So one of the things that we have not mentioned a little bit is that from the anesthesia aspect, the most dangerous stage that they consider is the intubation and extubation of the patient because of the aerosol transmissions and stuff like that. So it is interesting in our institution that the surgeons are not allowed in the operating room until the patient is completely put under the sleep and intubated. And also, we just have to stand outside the door until the patient is extubated. So, in the process of doing the intubation and extubation, and in order to protect ourselves, in order to protect the healthcare professional, we only had the anesthetist and the respiratory anesthesia technician to be in the room while those things are being done. And I think this is just a small facet, but it is many, to deal with it is many small facets.
Yeah. Thank you, Desmond. We have a question from Dr. Priya for Dr. Umar.
For Dr. Umar.
Good.
Good.
So, Dr. Umar, what is the sensitivity of PCR in your experience? Because previously it was like reported to be around 60% with 40% of false negatives. But now, as the literature is updating every other day, I was reading a literature last night. It says that PCR sensitivity has been improved quite well to up to approximately 90%. So I just wanted to take your opinion on this sensitivity of PCR in your experience here.
So PCR, like any other test, is dependent first of all on the quality of the sample. So there's a very widely circulated JAMA article which compared the sensitivity of PCR in different samples, whether it was nasopharyngeal swab or oropharyngeal swab or bronchial lavage. And I think that data might be up and down a little bit, but the principle applies that the first thing to consider with any test, and with this PCR in particular, is the quality of the sample and the origin of the sample. You will have much higher sensitivity in a bronchial alveolar lavage than you will in even a nasopharyngeal swab. Now, with that said, the sensitivity also you have to keep in mind whenever you look at the sensitivity, you have to have a gold standard. And so we are still learning about this disease. If we were to, for example, in the moment, imagine that the CT scan, the CT chest is a gold standard, then I think the sensitivity is about 75% or thereabouts if you take cumulatively all sorts of samples. Uh, if you take clinical symptoms wise, I think it's similar. So by far the most sensitive diagnostic modality uh, for COVID, for full-blown COVID, is CT scan. But you can't do a CT scan on everyone. Uh, the second best modality is the PCR test. That also is tedious. It's hard to collect a sample from the nasopharyngeal swab. It's really uncomfortable. I've had it done a couple of times, and I do not recommend it. But at the same time, this is what we have at the moment. This is the best we have got at the moment. Uh, as far as the technology at the back end is concerned, the sensitivity as far as limit of detection of the PCR kits is also improving. Previously it was that you were getting kits which were only picking up 500 international units of the virus, for instance, and now you've gone down to 200 international units. Now that still pales in comparison to these highly mature PCR tests that you have for HCV, for example, where you can pick up 11 international units per ml also. So the test is getting better all the time, like you said, and I think that will continue to be the case. The point of care tests that I mentioned will probably have lower sensitivity than the lab-based assays, but will still do the job most of the time reasonably well.
So, Dr. Umar, as like I'm a radiologist, so I'll be looking at things with a radiologist perspective. As far as the radiology societies are concerned, all over the world, they are recommending the CT test should not be used as screening or diagnosing COVID-19 disease. So just wanted to comment on that PCR still remains the diagnostic test, not like CT test, as far as the radiology guidelines are concerned. I just wanted to know another thing because I was just curious to know about this. That in your experience, how much percentage of the patients do you find that they were PCR negative on their first test, and then when you do the test again, they turn positive?
So, 2 points, both very important. First of all, I agree that the CT scan is not really a test that you can use as a matter of routine to diagnose COVID, but it is a test that you can use to monitor COVID. What I meant to say was that whenever you're comparing sensitivity, you have to have a gold standard so that you know what a true positive is. And so, the classic findings, the CT findings in full-blown COVID are so strong that they can be used as the gold standard, at least for methods of comparison. Now, as far as the second thing is concerned, as far as uh, we have had patients who've had a negative test before and a positive test later. That does not automatically mean that that their first test was negative. So we know that there is an incubation period uh, with this infection. There are people who get tested. I know that some people in government, for example, are getting tested every day. So the reason you get tested every day is because the day you get if you turn positive, you probably had exposure about 4 or 5 days previously, because it takes about 4 or 5 days for the test to turn positive. So, uh, so if people get tested sequentially every week, and if they are negative one week and positive the next week, that does not necessarily mean that the previous test was faulty. It just means that they had not been exposed yet, and they have been exposed since.
Okay, thank you.
Thank you very much. So I think bottom line is that whether patient is having any kind of surgery and it becomes COVID positive, the treatment is still there with the standard treatment of whatever is available in the COVID treatment. On top of that, I think this passive ionization by the plasmapheresis and the plasma therapy that offers a good option in this scenario, because it's available there and it is effective as well. Apart from that, the other antiviral drugs which are not available as yet, they can be considered if they are available. But yeah, go on.
Yeah, we have, in northern Pakistan, we basically have been doing plasma apheresis, and we have given it to a couple of patients so far. And the biggest challenge here is actually getting donors, because you see, convalescent plasma is blood group specific. Additionally, IVIG was discussed here also. We have already submitted a proposal to HSC, and there seems to be that we may get actually money without even HSC's some private funding for us to make IVIG. I think that's a far better way to go, because you don't have to worry about the blood group, you don't have to worry about any additional pathogens in the blood of the donor. It has several other advantages. Also, one big advantage being, you don't have to transfuse 500 mLs. You can get away with just a few couple of mLs rather than a couple hundred mLs.
Thank you. And I think with the COVID, positive COVID condition, the role of exosomes and their products seems promising, as shown by Bang Bang, and that it does reduce the inflammatory and other markers down, and helps in stopping the damaging cascade of inflammation and the cytokine storm. So I think it's worth looking into and running a trial of all these products. And I think Kuldeep will certainly enlighten us and will help in establishing the sort of a trial in this and also in the chronic liver disease, in which I think you can prevent this liver damage on a long-term basis. Yeah, and in regression as well. So, as conducted.
One more thing I would like to add is, regarding this, is that convalescent plasma is given to severe patients but not critical patients. Whereas another advantage of our exosomes would be they can even be given to people who are already in critical condition, because plasma is not going to reduce inflammation, but these exosomes can. So there's another advantage to that. Thank you.
And thank you very much. I thank Jawad, thank Umar, Fariha, Kuldeep, Desmond, and Bang Bang, and Dr. Vyas, and Hanif. We all have learned a lot from this interaction, and I think we'll keep on meeting regularly to discuss related issues. And I thank all of you individually and as a whole to to share your experience and your knowledge and giving your very precious time to us in discussing these issues. And thank you very much. Yes,
Thank
you
you,
said,
Dr. Tariq.
Umar?
I said
Thanks for organizing it and putting us together.
Thank you very much.
Thank you.
You're all welcome. Thank you.
Thank you. Thank you.
Thank you. Thank you.
Thank
Thank you
you.
very much.
Thank you.